Well, hello everybody, and welcome to this European Achondroplasia Forum workshop on assessing outcomes in a new era of achondroplasia treatment. So just we practiced this, I'm sorry. Okay, so just a few housekeeping things to go through. So this meeting is being recorded and therefore will be shared on the EAF website. Please keep your camera turned on so that we can see who's participating, and it will be really useful to see who's around when we come to discussion times. But when you're not speaking, when it's not your turn to speak, please make sure you're muted. If there is background noise, like we've already had, then we can mute your end of things anyway. So don't worry too much, but please bear that in mind. And please hide non-video participants. We just want to have the people in the room and feel free to share your thoughts at any time. Please use the raise hand function if you want to say something. Please use the chat function as well, just to put anything in the chat, and we will come to you. So big thanks go to the team at EAF, in particular, Kate, Alex, Zuz, and Rebecca. Becky, thank you so much for all your organisation. We have 131 registrants to this meeting, and that's the most we've ever had. So that is absolutely phenomenal. Thank you very much for all you've done behind the scenes, guys. So I'm going to kick things off. But I'd like to say thank you to our sponsors, to Ascendis, to Bimarin, to QED, BridgeBio, and to Sanofi. And without your support, we can't do this. So thank you so much for supporting us. The objectives of this meeting are to review whether our current outcome measures for achondroplasia, the things that we do day to day in our clinics, are they still fit for purpose in the era of therapeutic management? So the scenery is changing now. What we have been doing thus far, are those things still fit for purpose? So in order to work that out, we're going to explore real-world experience of available therapeutic options from both the patient and the healthcare professional perspectives. And we're going to review therapeutic options that are in the pipeline and do a bit of blue sky thinking and discuss potential future treatment paradigms. How can we combine things? What does the future look like for treatment of achondroplasia? Here's the gang. So me, Sérgio from Portugal, Antonio from Spain, and Geneviève from France. So we'll be taking you through this. Here's our agenda. So I'm going to give a little introduction in a moment, a little more introduction just to set the scene. And Geneviève is going to speak about therapeutic management of achondroplasia in the real world. And Sérgio and Antonio are going to share their experience of outcome measures in achondroplasia. Are they still fit for purpose? Then Antonio and I will be exploring the future of achondroplasia treatment. What things have changed recently? What does the future look like? And then at that point, we'll bring everyone in for a discussion as well, so that we can all share experience and share views. So before we launched this workshop, we sent out a survey to the early bird registrants to ask about experience of achondroplasia. And I'm just going to show a few of those results. So we had 50 respondents from a range of different specialities. Big up to our Italian colleagues. 27 responses. Thank you so much. And those specialities represented are from a number of different areas, but principally pediatric endocrinology, pediatrics, clinical genetics, and neurosurgery and orthopedics. Other people as well are clearly interested. This shows the expanding remit of treatment in achondroplasia, and great to have advocate representation too. Thank you very much. And from a vast range of different countries. So we asked people what best describes their centre or site of work, and the majority answered an academic institution or a university hospital. We asked as well whether people were collecting data for a registry, and the majority said no, but a few, just about 8, I think, said yes, which is excellent news. And on the right, you can see how they defined those registries. So National Database Registry for Rare Bone Disorders in Norway, Hospital Register, internal, local, non-government organisation, and someone answered various registry options. Do you manage children who are currently receiving vosoritide in clinical practice as opposed to the clinical trial setting? And 29 answered yes, and 8 answered no. I was one of the no responders because we don't yet have vosoritide available to us in the UK, unfortunately. And how many children are you following who are receiving vosoritide in clinical practice? So the majority, so skewed towards the left-hand side here, with the majority treating between under 10, a few 11 to 20, and some 4 responders are treating 21 to 30 individuals with achondroplasia. But at the top end there is 1 respondent who is treating 51 individuals with vosoritide. And we asked about what outcome measures are collected as part of standard clinical care, because we wanted to compare with what is happening in as the outcome measure of response of effectiveness with vosoritide. And we divided those groups up into the things that we measure physically, and things that we measure in terms of medical history, and outcomes regarding quality of life. So these were pretty standardized. So everyone is nearly everyone is measuring height and weight, head circumference, growth velocity, arm span, BMI, and pubertal staging. Have I got to find my laser pointer? No, too late for that. As well as body proportions and sitting height, and other things that were measured include blood pressure and some other measurements here as well. And in respect of medical history, things that were deemed of paramount importance to inquire about are neurological symptoms, pain, apnea, fatigue, and hearing loss. And in respect of other elements, adverse effects of the drug, any changes to blood pressure, orthopedic and musculoskeletal complications, nutritional aspects, and any other issues around sleep disordered breathing as determined by sleep studies. And with quality of life, there were different elements of quality of life that are being inquiries are being made over for these patients on vosoritide, so independent skills, functionality, psychosocial elements, academic achievements, and in respect of other people are asking what is other aspects of quality of life and sleep. What is sleep quality like? And where the individuals answered that they were looking at other things, we also asked whether there were any what those other things might entail. And again, adverse events come into the fore: craniofacial development and therefore complications, pubertal development, side effects of the drug, spinal stenosis, and tolerability. How are they managing to take those daily injections? And of those 7 who answered yes, we have other things to ask about. We asked, do you have any tools by which to measure those outcome measures? And 3 answered yes. We asked for some free text responses as well. Any other comments? And here's some of them for your perusal around dental and joint issues, parental expectations, efficacy of surgery, foramen magnum monitoring, body composition and body fat, limb lengthening issues. Oh, there's another one. Oh, yep, sorry. And there's a few more comments as well. I hope vosoritide will help. Okay, so with that, setting the scene, I would now like to hand over to Geneviève Baujat, who is a clinical geneticist in Paris. And she's going to be, she's got vast experience of using vosoritide in the real world setting, and she's going to share that experience with us. Over to you, Geneviève. Merci. You're on mute.
Thank you, Melita. Merci, Melita. And thank you for the presentation, very interesting that you gave us to illustrate where we are now. I'm not sure that I'm able to find
If you go to the top of the screen,
yes, for Susanna, but
and then to the right, view options, little drop down arrow.
Yes, but there is not the possibility for
request remote control,
because it is still. I think it is because it is still Susanna screen.
You can use Susanna's screen, but you need to ask to control it. So if you go to the view option en français.
No, but I'm sure that it is not as when we did that by the. I don't know.
Do you have a drop down menu that says request remote control?
Yeah. So I have the drop menu, but there is not the possibility. I think it is because I'm still on.
Oh, maybe you're on your own slides.
Alors, yes, now I can. It's done. Thank you. Sorry for this confusion. So yes, thank you for allowing us to discuss on this new aspect of the management of achondroplasia in the real world, with the fact of the treatment, specific treatment possibility, and this changed the last years, and we will discuss that with the various aspects. So indeed, I work in Paris in the Center of Reference for Skeletal Dysplasia with Valérie Cormier-Der and a large MD team. Without we cannot do all this work. So I have disclosures being involved in several clinical research projects. So at first, the title of this presentation is what does it mean to have a therapeutic option in achondroplasia, which is a really new paradigm for parents, for children, and for us HCP professionals involved in skeletal dysplasia. So as for you all involved in achondroplasia diagnosis and follow-up, we know much better than before that it is disease with quite much better follow-up organization and pathway, and we have age by age symptoms, complications, and rules for optimize and prevent the various aspects of the phenotype. And we also know that the burden for the families and the importance to have this MDT to look all the various aspects of this disorder. But with this new with all this follow-up, we know also that the adult life is really compatible with nice professional and social inclusion. So in France, we have this quite old now follow-up regular schedule, age by age, with various assessments and specialists involved. And we will have a new version hopefully in the next months. And also, and maybe at first in Europe and at an international level, we have more and more guidelines and consensus to better know what are the symptoms only due to the natural history of this condition, and how to manage with them, and to be most as possible in a prevention way to follow the patient and to have the better life and health as we can do. So what changed the last years is the Voxzogo introduction as part of the care and treatment pathway. In France, it was in December 2022 that we have the chance, we are lucky for that, to have the commercialization of this treatment for all people living in our country with the condition, with this condition. And we had at first the authorization by EMA, and then the commercialization. And between these two steps, we had a period of time with early access program. And this period of time was very good for us to do the organization and to make through our skeletal dysplasia network a common process to organize this treatment everywhere and to make feasible wherever lives the child. So this EAP was from June 2021 to December 2022, and we built this consortium, Achondroplasia France, as soon as 2020 to organize a diffusion after experimentation in our 6 centers, and to optimize the intrication within the conventional management and follow-up, this new treatment. And what was a bit particular in our country is the fact that we had the choice to start at first with children, the oldest children of our cohort, the children aged between 8 and 11 years, and then to progressively reduce the age at inclusion at first until 5 years, and then due to the recent authorization to until 2 years. And the objectives of this choice was to have a sort of equity to all patients with achondroplasia in our country, and to give this opportunity at first for the oldest one. So we had a coherent and common communication for patients' families, for the French association, APPT, and at first to the health providers in our network involved in achondroplasia for many years. So what does it mean and represent at first for families, and then we will see for healthcare providers and for the children. So at first for parents, sure, as you probably also experienced in your countries, this new treatment was lead at first to learn how to prepare, to do the injection, and to get organized at a family level to do this injection, and to have the follow-up that is asked when you have this treatment. You also experienced the fact that there was a large expectation of a specific treatment by parents and family at first, and the hope to increase essentially the growth velocity, the adult height, and also to decrease the disproportionality. This is something that often parents ask us in our clinics from birth and even before. And the adult height is, even if it is not the main symptom in or burden in this condition, it is the first question, as some families said. It is the first thing that is seen by others. They had some knowledge since for the last 10 years on the existing preclinical studies and the fact that new drugs will emerge in these years. And during clinics, through social media and bags, they had knowledge on this new treatment, but they one day were faced to the choice and to the beginning of these treatments. And this initial choice was done after information, which is very important, and type of consent. Even if we are not in a clinical research project, it is for them. We insist on this first step to have the choice, and no families was doing it if they don't choose the treatments. And they had this positive feeling to do something specific to help their children, their child, and to optimize the future. Of course, they had considerations around injections on a daily basis and on overcoming barriers. And the capability of the family to be able to do that was often one of their questions. But after they had the success to organize this treatment, and we can say that for the large majority of families, they succeed and overcame their fears, especially the injection. They did the education, they learned, and they get organized to have regular injection at the same time, and to do the regular assessments. And in our experience, they all showed a real, they learned really well, and they do really well this mix between their family organization and this new treatment empowerment. And they take the time to come for a regular appointment to the hospital. So we can say that there is a progressive and positive integration within the familial life. So for what are the main challenges? At first, the organization. So here we have for all of them a reference. Usually it's a pediatric geneticist for historical reason in France, or a pediatrician or endocrinologist involved in bone dysplasia. So we had the initiation and then regular calendar with a teleconsultation at M1 first month, then consultation at M3, M6, and per 6 months after. These consultations are quite long because we have to check the history, the physical examination, anthropometrics, vital signs, Tanner, and all was what Melita, you told us already. And of course, we try to ensure a good communication with the GP, with the MDT involved in the child follow-up. We give the possibility to the parent to have a local nurse to help them in during the first months to do the injection, to complete the education that they have at the first day. And we organize the visits for the first year, and we combine these new treatment follow-up with a conventional follow-up. And it is important, as you know, not to forget all this conventional follow-up. So for some centers, some hospital, without real willing to have this initiation on their side, we can share between them and our expert center between initiation and then follow-up in the center of competence nearer of the family place. So this is just a busy slide with how we share the conventional monitoring for this condition, which is just what we do for now many years, and the Voxzogo treatment follow-up. And Melita already you mentioned, we do what you said. We have this 6 months clinics or consultation, and once a year we have an annual assessment with bone age, X-rays. We have the technique of EOS, which is which allow a very low rate of eye radiation. Once a year we have blood and urine sampling for security parameters, and we of course check the motivation, and there is a registry named ACOM that you probably know. And we stop the treatment when we have the epiphyseal closure, and so both items, and the AGV less than 1.5 centimeter per year, on 2 consecutive measures with 6 months between 2 of them. So it is just to see how we try to combine everything, care and cure. So now, how to manage the patients and the family expectation of treatment? We, of course, prudence and part of uncertainty is very important for the long-term impacts and benefits, especially for height. And we know that there is a variability in the result of these treatments between patients, and we not know really well all the other impacts, especially on the adult life in children that will have received the treatment between at pediatric age. Of course, there is a good tolerance, but we have to be really open and to check if there is nothing that could be related to this new, quite recent treatments. We already discussed the stop of the treatments, and we also appreciate the inclusion as best as they can in their everyday life. The long-term motivation is ensured by the fact that they know usually we have several kids together in the same day hospital in tandem, and then we have the clinics with several children in the same time. So it's very nice for them, and they are happy to see them again. And we organized for now nearly 2 years workshop for them for the oldest treated patients above 6 years, and we try to have regular communication with the Families Association. We discuss the compliance and motivation at each visit, and we can see that there are many factors, especially the patient's motivation. And for children, at first, when we started with the older children, kids, they have to accept. It's different probably when they are very young, below the age of 3, but or above 5 years, the children have to be okay with the injection, and this has to be prepared. And the parents' motivation, the caregivers, the familial context also is a real factor to have a good compliance. And of course, the international experience sharing between physicians involved in this treatment are very important to exchange on how to keep this motivation on the top. So then, after families, for the healthcare, the professional perspective, of course, what we all look for is what is beyond the height benefits. Maybe the improved muscular force that was notified for the last months. This is something that has to be maybe better measured. Will we have a correction of the disproportion in children treated very early in life? And then what will be the modification in accessibility of activities and quality of life at home, at school, in sports, and how the parents are more and more comfort with injections and follow-up. So all these items are very important, and we have to capture these outcomes that are not only hate, to have long-term data and to always improve our process. So this is just a picture as you all probably have in your centers. The initiation is demonstrated by a nurse, a super nurse that we have, and usually the parents do a video with their phone to be sure that they will be able to do it the day after. The preparation of this first initiation is very important, to have a prescription and all the papers before this day hospital. So the MDT is aware of the treatment, of course, and they have to take account of that in their follow-up and to increase attention and prudence to interact with us if needed. And we, as in many countries, we have the same information system to share all data that is very useful. And we have a monthly meeting dedicated to achondroplasia to discuss some parameters, especially orthopedics, foramen magnum, spinal concerns. And we discuss each MRI and when we have points, particular points that we want to share, scoliosis or limbs modifications. The role of the GP is possibly to date too low for the moment, and it's not easy to increase his interaction, the interaction with him to date. He's as if they can be a bit afraid of this new drug that they cannot really manage, and they don't really know to date. So we have to increase their parts. And at last, the child's perspective. So we progressively, we are fascinated because the majority of them, after the age of 9-10 years, do self-injection every day. And they, especially when they are afraid of the injection, the fact to do it themselves, and they control, and it's a very good fact. So first days and weeks are not always easy, and they need time to get used to the injection. So it's important to keep on the importance of rituals and small means as cold, pressure, all that. And as soon as we can, we ask the parents to ask them to do the reconstitution and to participate to this injection. This empowerment is probably a real help to accept this injection. And through this injection, it's good for them. So they are proud of their own commitments and progress in the injection. So therapeutic management may result in improvements. They follow that in functionality, participation in sport or activities that some of them are limited for children above 1.20 meters. So it's self-confidence that increase with the treatments. So what does treatment change? What does it mean for children? They can, at first, they can travel even if they have the treatment. It's easy to go somewhere with the treatment. They can go to camping, they can run, and sometimes they are very proud because they can go up a closer size. And just for to illustrate the fact that we started with the oldest children, patient that we had, it's to show you a patient that we started at the age of 9 and 5 months, and who had a real gain of height with the treatment, and she's very happy. So this also is an illustration of what we said. The Atelier Voxogo is a workshop, Voxogo, and we have twice a year now this workshop for children older than 7 years, to train with fun and exchange with others. And it is a very good moment. And the parents, we take the parents in another room, and we discuss with them on achondroplasia. So just to finish, we will give you this some slide on a small study that we performed 2 years ago between France and Germany on 15 parents of achondroplasia children, to see how they deal with a new treatment. So I maybe to just recall 8 children in Germany, 7 in France, but a difference in age due to the choice of age of treatment. 6 years in Germany, 11 years in France. So families' experience with vosoritide was documented across 4 themes: awareness of vosoritide treatment, second, treatment understanding and decision making, third, training and initiation, and 4, management treatment at home. So at first, how do these parents were aware of this treatment? And what we saw that is the fact that parents become aware of vosoritide via 3 main routes. At first, for parents of older children, through research, online research that they did by themselves, or through second patient advocacy groups, and of course, and particularly in France, through the physician expert team in hospital, and because this is something that we communicate quite early. Second, the treatment understanding and decision making. For the child had a real role. What were their drivers? At first, of course, the increased height, the possibility to have an increased height and ability to participate in some activities. But of course, the concerns were needle phobia and losing, for some of them, identity as a little person, especially in familial cases. For the parents, the factors influencing their decision were, at first, the reduction in the health complication, and particularly the need for surgery. The second, the height gain, to increase functional independence, and the fact that finally we had a lack of serious side effects in the clinical trials. The training and initiation were performed in hospital initiation, as we said, or training session, and it varied considerably between countries. But the first injection made in a group helps to decrease the distress for parents and children. The at-home injection. So in France, we had this possibility to have support by a nurse for up to 30 days to adjust injection technique. In Germany, they have home nurse support available through a specific support program. And the parents persist with the treatment realization and discover adaptations to overcome the possible challenges over time. And finally, most of parents establish vosoritide as a regular part in daily life. So storage and logistics, maybe we won't keep, you know that it has to be stored at less than 30 degrees. So this is important in summer or in countries with heat. So just to finish, the conclusion, at first, the awareness and information of this treatment, we would like to emphasize all the sources, including the families association and the social media. That is today something very important in all life, and the drivers of decision making. But the fact that we have to have age appropriate support materials. Of course, it is not the same to start at 2 years or at 5 years or at 9 years. And the training is important, very important, preparation and training. And this is also a key to increase the treatment adherence and compliance. Voilà.
Merci beaucoup, Geneviève. C'était très bien. Merci. I think we can sneak in a couple of questions, one, maybe 2 questions. Does anyone have any questions for Geneviève? She has shared with us, I think, some of the greatest experience of using vosoritide in the actual clinical setting, in the real world setting. This is a golden opportunity to speak to an absolute expert. So does anyone have any questions for Geneviève?
Mohammed has a hand raised, Melita.
So who does?
Mohammed.
Oh, Mohammed, sorry, I couldn't see that. Mohammed, please go ahead with your question. Nice to see you.
Thank you. Nice to see you, Melita. Hi, Geneviève.
Hi.
Many thanks for your presentation. I have key question. I mean, with these new challenges, injections, and all the stuff around this medication, what is, to your opinion, the major determinant for the new elements in the achondroplasia narrative? Because the expectations of patients with achondroplasia in light of the recent changes are high in the patient journey. So what are the major determinants of the changes in quality of life from the parents' perspective and patients' perspective?
This is a very good question and difficult question, Mohammed, as you know, because it is not, of course, when they started, the hate was a major wish for the parents and but of course, quality of life, how to measure it, and possibly it's a combination of several aspects. Endurance, fatigue, the pain, fatigue, the accessibility to home stuff, and to be able to catch, to take things. So it's probably not only one determinant, one item, and this is why it is difficult in a registry that are by definition restricted to some items to have a good simple answer. And I suppose this is the same for you, my colleagues. We are always very happy and surprised to hear children and families treated now for more than 2 years and having new possibility in their life that are not hate, not only hate. By instance, as we said, the course, the fatigue to run, to make sport, to have less fatigue than less pain. I already said that. And this morning I had a little girl. She told me, now I can go to this swimming pool. There are big toboggan, and it was before only for children more than 1 meter and 20. But it's a detail, but for her it's very important. Is it quality of life that it is a 10, it is something that seems important to be able now to do that. Voilà. It's just an example.
Thank you very much. Thank you for your question, Mohammed. I think in the interest of time, we will move on now to hear from Sérgio and Antonio, but following their talks, there'll be some time for discussion. So maybe we can bring Geneviève back in at that stage if anyone thinks of any questions later on to ask her. So thank you so much, Geneviève. A great, yeah, thank you for sharing your experience with us. Sérgio, I'll hand over to you.
Okay, thank you so much. So we'll keep on the discussion actually on how are our outcome measures today, and are they fit for what we want to observe and what want to measure. So this will continue on these sessions, me and Antonio trying to raise continue to raise several of these questions. These are my disclosures. And this will be a bit the order of the session we will be having now. How do we measure outcomes beyond height? And these will be the three main topics: anthropometric measures for disproportion, quality of life, independence, and functionality. And how can we capture this data, probably using registry. And then we will have the second part as an open discussion for questions and to discuss all these issues together. So as Geneviève very well showed us, we have these three perspectives of the clinicians and the science people, the caregiver and the patient. It's also well summarized in this paper if you want to have a look. And that they have, of course, common expectations on the treatment, but we have probably more questions than answers for many of these issues. We want to, so the efficacy so far is measuring height by itself. And we are, I think we actually on the survey, not all, but almost all, everyone measuring height for efficacy. But we wanted to measure more things. And one of the things that parents and as care providers want to tackle is the disproportion. So we think we know well how disproportion affects children and adults with achondroplasia, but one of the questions we should today discuss is, are we measuring it well? In a way of seeing, we also saw in the survey that we're probably measuring height and limbs, but are we measuring, for instance, craniofacial features and other things properly as we should? So what in the clinical setting, this is on your left, is basically what we measure or what we used to measure as part of the multidisciplinary follow-up. As you saw on Geneviève's slides, before the treatment, we were always very busy also with the multidisciplinary care and prevention complications. And often the growth were basically very basic measures, and then we would plot them in the achondroplasia specific growth curves and just having a notion how things were. For the clinical trials, for vosoritide and other drugs, we are measuring in much more detail. And even all the calculations done can be done differently and have been done differently between studies and quite difficult to compare. So in this setting that we are kind of a hybrid between the classic and a clinical trial setting, trying to answer several of the questions, we need to find a more standardized way of a middle point between these two settings. We have the achondroplasia growth curves that we've seen. So for height, for several populations, we have good data on this that we base on. And we also have for other measures than height. These are the basic idea that we have for achondroplasia and for average height and the difference. But of course, it's very individual, and we will have differences in individuals also for the treatment response. So if we want to measure other things than height, the first thing then is disproportionate, and the shortening of the limbs and the craniofacial features will be the other things to aim on. We know that the disproportion aggravates with time, so it's progressive. And this is one of the expectations, that the treatments can have an impact on this, and then secondary on the quality of life, on the region, as we've shown. So one of the things to measure this is how the quality of our anthropometry or oxology in evaluating each children. And we know, and it's been discussed a few times, it's quite variable. And it's variable, all these items, professionals, equipment, technique, all individual child, what to reference all the calculations. And it's quite important for each of the centers to have a protocol to define how they are measuring things and having it the most standardized way. So in here, this picture, you have all the equipment that we have here in our hospital, for instance, in Coimbra. It's not a huge hospital, but you can see how the variability, and we can measure it. And I can assure you that measuring a child in each of these equipments will give a slightly different number or value. And if you measure disproportion, the variability may even be more. So we need to standardize and measure the same equipment, calibrated equipment. And of course, the most probably important is to have the same persons, the same professionals making the measurements with training. Of course, the centers that have the clinical trials are used to it. Others probably need a bit more attention and training on this. And this is, for instance, our wonderful nurses that do all the measurements in every child with achondroplasia here in our hospitals, and also do it for the clinical trials and also for the achondroplasia children being treated. I wanted just to pay attention that there will be a new article that is in preparation regarding some extra guidance on the anthropometry of people and children and adults with the skeletal dysplasia. And probably in a couple of months, we will have it available also to help on this standardization. And now I'll give the word to Antonio. Antonio, if you want to gain control of the screen and continue, I'll be back after.
Okay, Sergio, do you hear me? Yes. Okay, thanks, Dr. Sousa, for the presentation, and thanks to European Achondroplasia Forum and the steering committee for giving me the opportunity to take part in this project. I am Antonio Leiva, orthopedic and trauma surgeon, member of Achondroplasia and Dysplasia unit in Malaga, Spain. In clinical practice, we have experience in follow-up from birth to adulthood, and we are performing limb lengthening in achondroplasia patients during more than 30 years. In my case, the last 15 years. In research, I'm a medical doctor developing my doctoral thesis around the impact of limb lengthening, not only in height, analyzing to anthropometric measurement, proportionality, health-related quality of life, functioning, and metabolic profile in achondroplasia patients. And I'm principal investigator in Research Institute in Malaga, developing clinical trials with vosoritide and infigratinib. I'm trying to progress.
Antonio, have you requested?
Yes, I requested by now. Okay, yes. We are going up exploring a practical way in anthropometric measurement, and we will develop another outcome measures like quality of life, independence, and functionality. Go on with anthropometric measurement, projecting a very practical way with the experience analyzing the impact of an intervention like limb lengthening in achondroplasia patients. We think that this anthropometric measurement, measuring firstly and 6 monthly, are essential to analyze the impact of any intervention in achondroplasia, surgical or medical. The clinical practice is very arduous, and we have to focus in the main anthropometric measurement, highlighting height, weight, arm span, sitting height, head circumference, and foot length. not only in absolute number, even more important in standard deviation. Even more important is proportionality. And with this anthropometric measurement, we can perform an integral analysis of proportionality, not only relation between sitting height and height. The proportionality analysis should be more complete, adding head circumference height, sitting height lower limb relation, and extremity relation with sitting head. And of course, extrapolating to growth charts, trying to compare with similar population. Even in Europe, it is not honest to compare Spanish population with Swedish population. I think it's necessary to create our own country growth chart to be more accurate in the analysis. And of course, we need tools that help us to perform an adequate and accurate follow-up, pharmacovigilance, and create big database with the objective to get the ability to find which patients are responder and which not after treatment. We are developing this local application, Achondroplasia by VIMA, a research institute in Malaga, capturing all these anthropometric measurements. And here we have one example represented in the application of height follow-up in patients with medical treatment. Women, average growth pink line, and green line our patient in treatment. Vertical blue line is vertical blue line. Treatment beginning, we can point wherever we want. Beginning of a treatment, beginning of puberty. In this case, this patient is moving from 0 standard deviation to 1.5 standard deviation after medical treatment with vosoritide. Another example, in this case, after lower limb lengthening. In pink line, woman, average growth. In green, our patient. And vertical line, limb lengthening beginning. And this is the result after the treatment. Another example, analyzing proportionality after limb lengthening, relationship sitting height and height. With these three examples, I'd like to emphasize the importance of using tool register data and create a big database. Talking about another outcome measure, more important and more difficult to measure than anthropometric measurement, are quality of life, independence, and functionality. Exploring this concept, we moved to World Health Organization in 2001, International Classification on Functioning, Disability, and Health, and the extension in Geneva 2007, Incorporation of Children and Youth version, in which quality of life is interpreted like more complex term, analyzing structure, corporal function, activity, participation, environmental and personal factors. All these domains are integrated in the term health-related quality of life, capturing psychosocial, economical, and social impact, burden of the disease, and health resource needed for treating this condition. The main questions for me are: have achondroplasia, like a condition or like a disease, real impact on health-related quality of life? And how do we measure this variable? Probably the most important question. Apparently, huge evidence relating achondroplasia and quality of life has been created, concluding lower score in self-esteem, psychosocial, economic and familiar domain, more pain, very, very important variable, more depression, and more anxiety. Very, very well summarized in a really good literature review is the work performed by Ireland in 2021 with more than 1,664 records, concluding experience limitation in physical functioning and poor quality of life outcomes. After analyzing the evidence, we can affirm that although there is lack of evidence and usually general questionnaires are used, there is a negative impact in health-related quality of life due to achondroplasia condition, but very far from having good answer, we have more questions. What is the intensity of this negative impact? What are the domains more affected? Are all the comorbidities implicated? Only hate? Probably all the comorbidities are implicated, but it's a reality that hate is the variable more studied and therefore seem to be the comorbidity more important. Hate in and of itself is a factor in quality of life, LORM 2020. Better physical domain, taller than 140 centimeter, Matsushita, 2019. But we cannot forget the importance of the rest of comorbidities, probably more implicated in health-related quality of life than hate. In fact, where Fund 2021 not only talk about hate, they incorporate proportionality and tell us quality of life may be reduced, attributable to the physical challenge of disproportionate short stature, not only short stature, disproportionate short stature. And why is there a lack of evidence? Probably because we are not using correct measuring instruments. If our data are not enough accurate, our conclusions probably will be wrong. We need complex tools to agglutinate the maximum of information. Probably the most powerful tool to register quality of life is through qualitative interview. But we need more practical ways in our routine. And this we obtain with quantitative tools encompassed in patient report outcomes, PRO, which quantify the domains without external interpretation, with two main objectives. First, for analyzing the impact of a condition like achondroplasia. And second, it's possible to analyze the effect of an intervention. These patient report outcomes or observer report outcomes have been very, very well agglutinated in achondroplasia patients in Blanca study in 2019. We took part in this study. Some of them are PET score from children, parents. It's a general tool for acute and chronic condition, Likert scale, 23 items, physical, social, and emotional domains is required. A Q5D jump pending to validate in children and in achondroplasia. Of this questionnaire, I like to use the visual scale of health from 0 to 100. Another patient report outcomes is quality of life in short stature job for children and parents. A specific failure for stature, for short stature, like Likert scale, 22 items, domains for children, registering physical, social, emotional, confidence, and treatment domain. Very important treatment domain in this era. And for parent, future and parents' impact is analyzed. In Blanque et al. 2019, the study concluded short stature specific quality and generic PET scale questionnaire have both been psychometrically validated and might be considered for use in research with children with achondroplasia. Another one is achondroplasia personal life experience scale, APELS, specific patient report outcome, Likert scale, 21 items, physical, social, emotional, family, friend, school, domains, and ISMs, achondroplasia child experience measures, a really specific tool developed by Fisher team, registering in one side symptoms, comorbidities, and in the other side impact in functioning, emotional, social, well-being, and need for assistance. Another one, analyzing functionality in an isolated way, is WIFIN, Functional Independence Measure for Children. It's a generic tool that registers self-care, mobility, and cognitive, capturing change in children's functional ability. Chronic disability validated in achondroplasia we can use in patient that is treated with medical treatment or surgical treatment. Another one is the modified gait efficacy scale. Gait confidence in adult after surgery or time, pending in achondroplasia population. And probably the most important comorbidity with a real impact in health-related quality of life is pain. It's necessary to have a register around this variable. We can use breath pain inventory. After the multitude of patient-reported outcome tools, we have to extrapolate into clinical practice. In this way, we have elaborated a work notebook with this patient-reported outcome, analyzing them before, during, and after an intervention like limb lengthening, with the objective to know if health-related quality of life is modified and which variables are relationship with this modification. In the future, this work notebook will be incorporated to the local application. From evidence to clinical practice, relationship, health-related quality of life, achondroplasia, and intervention, we can notice the first result of patient-reported outcome after medical treatment like phosphatide. It's a very, very updated information. Seen modification in physical domain when height score is modified. Another example from evidence to clinical practice. After limb lengthening, we analyze health-related quality of life through PET scale, APOS, quality in 3 similar groups in demographic and anthropometric variables. S0 red group, achondroplasia patients without limb lengthening, S1 blue group with lower limb lengthening, and S2 yellow group with lower and upper limb lengthening. And we've seen modification in total score of health-related quality of life increasing when limb lengthening program is progressing, and in each domain. In total score first, we can group 0, group 1, and group 2 enables in children and parents, quality children and parents, and PET scale children and parents without limb lengthening, after lower limb lengthening, and after upper and lower limb lengthening. And in the rest of the domain, physical domain, emotional, social, functional, and gait. A conclusion, probably, if we hope that medical treatment have an impact in all comorbidities, we should be more ambitious in our analysis and pharmacovigilance. And it's not enough to measure or to analyze anthropometric variables or health-related quality of life. We have to analyze the impact of any treatment in all variables, in all comorbidities. We have to register anthropometric measurements, health-related quality of life variables, radiograph, spine parameters, MRI, metabolism profile, in summary, use tools to analyze all the comorbidities. Thank you very much.
Thank you, Antonio. So I'll finish with a few more slides. So the questions we should be debating today is how then we can decide which measures will help us, are more reliable, if we have all the measures we need, if extra measures need to be built or improved, and how can we collect all these data in a standardized way and meaningful way. So we have all these questions that have been raised, we've discussed today on the survey that Geneviève posed, and they're all on our mind. And we know that for the clinical trials, many of them will not even attempt to have an answer, and we all rely on real-world experience to answer them. So it's this coordination of care that it's needed to be able to give answers to this. So this paper, this figure is from here. I was trying to, yeah, okay, sorry. this paper that Melita and several of our colleagues here today participated, try to propose a number of items that should be included in registries. So the main hope that we have is that by participating in international registries, we are able to pool and collect standardized data that are able to at least answer a few of these questions. So this paper that then later, Melita, you can discuss a bit better, try to propose a list of items that for each age should be looked up and have data collected as much as possible on each individual patient. It's quite important to try to do this either at regional level, national level, and international level, and to have these platforms where we can homogenize and use a similar approach. It would be quite important. So there are several examples. We heard about Malaga. I don't know if Geneviève, later you can discuss how this has been collected nationally in France. I will mention CrècheNet and Irving that took on that paper that showed to try to organize this collection of data. So CrècheNet is a German registry that is now international. Klaus Monik is one of the persons taking the lead on this, but unfortunately he cannot be here today. I will show you a few of the slides, but are mostly many information online that you can collect. So it's a registry that started several years ago, mainly targeting children that were having growth hormone or other growth treatments and trying to measure and monitor that impact. And they created also a module for achondroplasia that is trying to elaborate to try to collect this real world experience on these items, not only anthropometric assessments, but also other items, demographic items, and natural history of each children, developmental status, clinical findings, and some of these tools that Antonio showed on pros and patient-related outcomes. In this registry, you will have we have this workflow. It's done to try to do it at the same time as the clinic, as the consultation hours. So it's mainly a tool also to collect data, but use it on your daily life and help to simplify a few of the issues that we have. And even calculating the growth velocity, plotting, as Antonio showed, it's also possible here. And you can also include other measures that can be collected. It can also then complement the anthropometric, the detailed anthropometric measures with questionnaires, either done by the physician that is evaluating the child or by the patients directly. So I'm here a few of the snapshots. There's a demonstration version that you can also access and have a look at the registry. And if you would like, if any of the centers would like to join, it's important to contact the University of Leipzig, that is the headquarters of this registry, and especially Ruth Gosch, that is the person ahead of the registry. And you can see, you can have more or less collecting data according to what you are measuring. But of course, here probably is what is the minimal that we should collect for achondroplasia regarding the anthropometric measures. They will calculate immediately the standard deviation for either the CDC or the WHO curves, but also the achondroplasia curves. And that's quite helpful because it's not easy to have an automatic way to have a value for the standard deviation for the achondroplasia curves. So the curves use also the Northern European curves. And you can have here a few examples how you can put it in the same plot, the growth chart, the developmental stages, and also the time of medication, and to try to see here the impact. But probably more connected, what we are discussing here today is the possibility of having patient-reported outcomes directly. So in here, what they developed is like while you're in the clinic, they will be produced a QR code that you can give to the parent, the family, and they will fulfill it. And for now, they have introduced the apples, a survey that Antonio mentioned, and also the Achondroplasia development recording. These are the other questionnaires that are available. Also, QEC is available, and other, but they are basically in a very reduced languages. So I think it's German, English. I'm not sure exactly at the moment how many languages are included and available, but what Ruth and Klaus mentioned is they are looking for collaborators to adapt and validate, especially apples, in the different languages, to be able to try to make it as much inclusive as possible, the FreshNet. And mentioning also, so the European reference networks, especially Eureka, the endocrinological networks, so the ERN endo and ERN bond for endocrinology disorders and for bone disorders have produced a joint registry. So at the moment, I ask also, so Natasha is the responsible for this registry. It's very well organized and had different modules. One module was also created based on that information on that paper that was just mentioned. And is ongoing, so people can submit data, especially for members of these networks, but it's also open to others. And the thing is, I think it's not as many tools and not user friendly as FreshNet to monitor growth and treatment in children. So it's quite comprehensive and more useful probably at the moment for teenagers and adults. And I think probably the main conclusion at the moment, they are complementary, these two types of registries, one for more adults and long-term, and also to compare with other rare bone disorders like the Urbone, and FreshNet more focused on measuring growth and the impact of treatments in children with different disorders, including achondroplasia. So, these two registries are also working together. One can export data from one to the other later on in bulk if it's needed to be able to pull data together. So, and this is the slides we had prepared, Antonio and me, and we would like to stop now to open the discussion to everyone. First questions on, we'll have 20 minutes to discuss. I just have here the information, and we will stop at 20-25 minutes for a break. So I don't know if we have already a few questions here in the chat, or if someone wants to raise their hand.
Sergio, waiting that somebody raised their hand. I think that this question is really, really, really nice. I love this question. It's a great question because I always have the feeling that we are losing information. I don't know if you have this feeling all the time. In our patient, we are losing information. At first, it seemed very easy. We have to look the comorbidities to measure, to analyze its comorbidity. Foramen magnum with MRI, obstructive apnea with a sleep study, sore stature with head. It seems easy, but in fact, it's not easy. No? There are several comorbidities that I think we are not interpreting or analyzing well. For example, the obesity. We don't know the real physiopathological mechanism of obesity in achondroplasia patients. How do we analyze the obesity? With body mass index, we know that this variable is not robust in achondroplasia. Do we perform impedance in our patient, or do we perform MRI for body composition in our patient, or blood tests analyzing metabolism profile? That's the question. How do we measure some variables like, for example, obesity?
Yeah, I also don't know how to question. I think everyone is measuring weight and a few measures also for the waist, but it definitely important at long term to have a look. We have Valerie here that raised their hand. Hello, Valerie.
Sérgio, thank you very much. I have just a quick question. For example, you are using CRESNET, but you are also filling the registry from the ERN bond. So you are doing both, and you have somebody dedicated to this database, because it's a question of time and it is quite time consuming. We just want to have a minimal data set.
This is one of the questions I almost did to Geneviève before, is how was the team adapted with all this effort? Because in here we struggle the same. So at the moment we have not yet the permission from the hospital in here in Coimbra to use either of these registries, but we will try at least with the resources we have. But the main thing, I think we need to have more human resources to be able to answer these questions, and we also need to find funding for this. So I think either for these international networks, but also, well, CRESNET is being funded independently, so it's also another way. But of course, the just to put the data there is quite difficult at the moment. And I think the feeling that Antonio has, that we are missing data every day we have. So for instance, we try to measure a few things extra, like the hand or a few other measurements, but then the parents come, and the last clinic we had like a couple weeks ago is a family saying, why you measure the hand? I think the feet are getting much bigger. You should measure the feet because it's much better for, and they're right, we're not measuring at least here the feet, and they're feeling that was that the measure most important to be able to give stabilization, and they observing improvements much quicker, for instance, for that. So even for measures, I think we don't have, I think, staff enough for that. Make the same thing. I think we should make photography registries and everything that more easily. But at the moment, our experience is we don't. Even we started with quality of life questionnaires that we had to drop because we couldn't do it consistently all the time, and at the moment we are not collecting as accurately as before because the numbers increase, and then we cannot do it in a homogeneous way here. But Valerie, I don't know if you want to
no,
how are we doing in Paris? Do you have a registry in France, or how?
We are working on it, but we have exactly the same difficulties because it's time consuming. So we need human resources to fill it, and we just want to harmonize it. So we are facing the same difficulties. So maybe one possibility will be to have a funding for all of us to fill a registry, because it's one of the major difficulties. And if we want to have a common assessment and to have common follow-up, we need to harmonize our follow-up, and at this period of time, because of human resources, it's quite difficult. So we are working on a local database, but we need people to fill it. We are unable to do it.
There are, Sergio, a couple of comments in the chat function as well, if you'd like to have a look in there too.
Okay, thank you. So we have Yana Alum asking, from the child, now adult, whom underwent complete limb lengthening at a time when the extended fixators were the only option. I upload the current presentation from today's workshop. Okay, thank you. And Sophia Saka asks, how about contractors? How can we measure improvement, especially in the area of vosoritide? I don't know if Antonio, you want to try to answer that. How can we measure better the contractors, especially imagine the elbow?
I think that the contractor it's a very, very important point. In our experience with limb lengthening, we not only see contractor in the elbow because it's a natural situation in a achondroplasia patient. We see contractors in hip, in knees, and in ankle after limb lengthening. We have learned that when we perform big lengthening around 8 centimeters in 3 months, appear big contractor, but the patient with achondroplasia have a very, very good situation to resolve that problem. Then I think so that now with vosoritide, where the increase of annual velocity of growth is 50%, if one patient is going to grow that year 4 centimeters, and with vosoritide is going to grow 6 centimeters, I think that there is not going to be problem with contractor, because it's only 2 centimeters in all 1 year. And we have seen very, very big contractors after limb lengthening, very, very big, total fixed knee. And after a big physiotherapy, the patient with achondroplasia have a redundance of muscle and tendons, and always or almost always resolve that contracture. There, I am not awareness about the contractors with medical treatment, but I think that it's very, very important, of course, to measure, of course.
I think our feeling is that the measuring of the angle is the most inconsistent one. So it's quite difficult to actually go for, I don't know if people have.
It's difficult to perform the evaluation. Obviously, you have to use angles, you have to use goniometers, but it's very difficult to be accurate measuring angles. But it's necessary, of course.
Melita, I don't know if you want to comment on any of these. So having probably a lot of experience in clinical trials that have used several of these scales and forms, what is your feeling? What would be because we would need to select a few of these questionnaires, right? To see if they're, and try to use them as much as we can all together, and having in different languages. And I think it also useful if it is these type of approaches that the patient receives them on their, and they fulfill it, and it goes directly to a centralized, and because the other problem is not the time to collect and time to put on the registry, is also time to analyze the data. So this is another struggle that we have on the who will be every year analyzing that data in total.
Yeah, I fully agree with Valerie's point, which is I think Antonio's slide really brought home how many different tools there are. I don't think, well, our experience from using them in the clinical trial setting is that none of them is perfect. We are going to need a combination if we're going to use what already exists. So we potentially have an opportunity here to cherry pick some of the good things from those different tools and perhaps make a new tool that doesn't necessarily have to be recreated, but just by picking all the different things from the different tools that we use, putting them into one application, and yes, having the parents and the child complete those electronically, because Valerie's point is we are all very busy, including parents and children, and taking the amount of time to fill in all of these different things is not realistic in the clinic setting. But yet we're not trying to recreate a clinical trial setting in the clinic. So we have to reinvent this wheel slightly, and be realistic about what we're trying to achieve and how we can do that reliably and accurately. Because as you will see from my talk, accuracy is key to being able to detect these changes in response to treatment. So we need to do things properly and accurately, but being realistic that we are absolutely at capacity with everything that we do. So doing it a new way. I don't know if there's an opportunity. We have 4 sponsors taking part in and helping us with this event today, and others also registered. So perhaps there is an opportunity here to club together. I was at a rare disease event last week where we acknowledged that pooling data rather than reinventing natural history studies each time a new trial comes up in the same rare disease, not necessarily achondroplasia, but across the 10,000 rare diseases, pooling resources, pooling data, pulling together might be a much more efficient way to do things. So perhaps we have an opportunity here to engage with our sponsors and collect accurate data in the clinical setting, because it's of interest to everybody.
I think Mohammed raised
it. Yeah.
Yeah, thank you very much, both Sergio and Antonio, for the beautiful presentation. Now we are facing some issues related to both treatment with vosoritide and limb lengthening in those children who started treatment later. So would you like to comment on how you are dealing with these issues? Because we have some of these patients treated with vosoritide and they are under limb lengthening. And I guess there are some even bone changes, what we are, observing, and we don't know exactly what's going on at the level of bone. So would you like to comment on this? This is my first question. And the second one is related, are you doing any studies regarding reproducibility of quality of life over time after adult height achievement? So because this could be even change, based on the, the age or other factors involving these patients.
Thank you, Mohammed. I think for the first question, Antonio, probably Spain,
Yes.
Italy are
Okay.
the main countries.
The second year. Okay. The first question, thank you, Mohammed, because it's a really good question, and it's a thinking, it's a thought that are on the table. In the next talk, in the next hour, with the webinar with Melita now, I'm going to talk about that, the possibility of combination of treatment. And that is a very big discussion. When start medical treatment, when start limb lengthening. It's possible to combine during limb lengthening. I'm going to talk about that in half an hour. Then I'm going to to wait the answer.
Okay.
Thank you for the question.
Regarding the second question, I don't know, Svein, can you answer about the data on adults and how can will be able to long-term capture the maintain of quality of life? That's what I understood, right? So not only the gain of quality of life while they are children and then actually to be able in the future to compare the adult population that had treatment versus the one that didn't have treatment. And if what we wanted, the impact on adult also, how can we show that difference? I think that was the question, but I'm probably not the best person to answer it. But if Svein or someone that do more adult clinic can give us an answer.
Sergio, it's a really good question, because the problem is that we don't have data about the quality of life of this patient in adulthood, in achondroplasia patient. There is a really nice article that the Matsushita article in 2019 that try to analyze the quality of life of adulthood after limb lengthening. It's an intent, but because it's a retrospective view of that quality of life, and it seemed that that quality of life, it was better after patient get around 140 centimeters. But they are working with retrospective data, and that it's a big bias. That's a very, very challenging to get updated data about quality of life in adulthood.
Thank you. Svein, do you want to any comments?
Yes, I can try. I think first of all, I think I would like to thank the presenters. I really enjoyed the presentations today, and I think you ask some great questions, and I don't have any answers to your questions. But I think it's important, of course, to continue measuring what's happening into adulthood, and we can keep on discussing what kind of instruments. Of course, pain is one of the keys, I think. Functionality. Kind of walking, reach, the ability to be independent, not asking for help. So that's like one of the key issues, I think, in adults, becoming even more important when you're getting older. And of course, the ability to continue work. We know from, at least from my data, then that at around age of 40, the majority even had to reduce or went into the disability pension. So, and mainly because of pain and spinal stenosis. And again, we know that maybe between 70 to 80% will develop spinal stenosis at some point during life. So of course, having some measurements of the degree of spinal stenosis, the severity, how we could measure that, I'm not sure, but definitely I think that's one of the key issues. And of course also sleep apnea. We know that's an issue in children, but it also is a major issue in adults. And so medical complications, functionality, pain, and also I think it's important, as has been mentioned today, that the overall health-related quality of life. What does this kind of impact? I mean, the combination of medical complications, pain, and functionality adds up into the really key issue. How is it to live with achondroplasia, and can we see any kind of improvement? And I think that's the link that the pharmaceutical companies actually really want us to show. It will take maybe 10 to 15 years. But I think if we don't start collecting these data, we will never get them. And that will give us the final answer on what's this treatment, what we hope they will achieve and what we think they will do, but we need to collect it.
Can you, in Norway, are people being treated with vosoritide, and is there any registry that, how's it happening?
Well, for the first question, the authorities has been postponing this decision, yes, waiting for more data. They now finally decided to turn the thumbs down, but we will have, I think, a second round. So they go into next negotiations. I had an email from Biomarine this day, so I think they will have a second round. But at the moment, we are not allowed to prescribe vosoritide. For the second question, we have established a registry for rare disorders, rare bone disorders, which are still in the early days. It was upgoing in the autumn 2023, but I think we have around 100 patients included already, which is, I think, 1/3 of something of the population we have with short stature. So this will, in the long term, will give us some of these data, and more patients, those we see at the achondroplasia clinics for children, are asked to participate, and then we will be able to collect longitudinal data, and that's on a national level.
International.
Unfortunately, we are not allowed, as I think for your country, to access CRESCNet and the EU RR Bone. At the moment, we continuously working on that, but at least we have the data, so it will be a much easier part to add them into the registry, hopefully when we are allowed to do that.
Thank you, Sveinung. I don't know if anyone else from other countries want to share any type of registry or any type of data collection that has been done. Otherwise, I think we can do the break. I don't know if...
Sergio, only one reflection, one thought. I think that we are talking about what to measure, but probably the most important is how to measure. In the last word that you exposed in the presentation, leadership by Alani and Melita, I think it's a very, very promising point for a start. The real world evidence in achondroplasia. The objective of this real world evidence in achondroplasia, it's amazing because it's an international, applicable, standardized, and prospective register. I think that it's very, very important, prospective, because all the information that we are using up to now is obtained through retrospective studies. The biggest and useful study, Clarity and Leiva-Gea, both retrospective. Then bias and error, that's a retrospective study we know. No? And in this paper that you saw, I love the figure number 1 because it's a really well summarized of this. Talk about this question, what to measure and when to measure all medical issue. But now I think that we need a second paper. We have work. How to measure. For example, in medical issues, talk about pain. I need to refer pain location and pain scale, but what scale do you use in your routine for pain or quality of life? I think that it's necessary. I expose a lot of patient-reported outcome tools, but what is the best? It's impossible to use all the quality of life. Or thoracolumbar spine. Do you perform lateral X-ray? Do you measure spinal? What parameters of a spine it's necessary to measure? Then, if we want to standardize register, we need a standardized tool and standardize all the parameters that we are going to use. Then it's work for everybody. Now, how to measure? What tools we have to use?
Okay, so let's make a break and then we'll continue the discussion after Melita and Antonio's session.
Welcome back, everybody. So this is the second session where we would like to turn our attention to what the future looks like. So we now have vosoritide as an approved treatment for children with achondroplasia. We have new treatments, potential treatments, also in the clinical trial setting. And if they are successful, this will be a very busy space in the near future. We've heard from Antonio already about the limb lengthening surgeries and the impact that they can have. And so we would like to turn our attentions to what some of these things might look like in combination in the future. So in order to do that, I'm just going to give you one of my whistle-stop tours of the vosoritide data and really set the scene for what new treatments are in the pipeline to see how the future may look. Sergio, who's already alluded to the fact that there are lots of different things, bits of equipment in his small hospital, small but beautiful Sérgio hospital, that you use to measure children with achondroplasia, and how important it is to get it right. So please bear that in mind when I tell you this data, because we're not dealing with growth hormone axis, an issue in which you give growth hormone therapy and expect to get 10 centimeters. This is not a growth hormone axis issue. This is a growth plate targeted condition and therefore treatments. And it's a very different landscape. So please bear that in mind. And I'd also like to give a big shout out to my team, who I can see are also on the call today. Hi, everybody. My team and many other teams were fundamental in allowing this data to be generated. They are so skilled, they are so caring of our patients and our families. We are nothing without you and what you have done to help us. So a big shout out to you guys and to everyone else's team as well. Thank you. So my disclosures. So I'm just going to start off talking about vosoritide. That's where we have the greatest level of data and information and knowledge thus far. So just a quick recap that vosoritide is a synthetic form of C-natriuretic peptide. The idea behind this drug is that it inhibits the FGFR3 signaling pathway, which is activated by the recurrent pathogenic variant that causes achondroplasia. So if your fibroblast growth factor receptor, as it sits across the cell membrane of a chondrocyte in the growth plate, is activated, the downstream effect of that is to inhibit bone growth, to inhibit endochondral bone growth. So in children with achondroplasia, there is a constant inhibition of endochondral bone growth. And the idea behind vosoritide is that by triggering another signaling pathway, we can inhibit the FGFR3 signaling pathway. So an inhibition of an inhibitory pathway releases that inhibition and then allows bones to grow more normally. That's the premise behind vosoritide. C-natriuretic peptide itself, the ligand that stimulates that cross-talking pathway is, yes, a naturally occurring product in the body, but if we inject it in its natant form, then it will last for 5 minutes, and that's not long enough to get it where it needs to go, i.e. the cartilaginous growth plate. So vosoritide is a synthetic form of C-natriuretic peptide, which means that if it's injected subcutaneously, it lasts for 45 minutes. And so the clinical trial data that has been generated is based on using vosoritide on a daily basis. And the clinical trial program has been, well, it started off with preclinical studies using a mouse model of achondroplasia. Might this thing just work? And it looked like it might do. So then the very next stage, and I've already alluded to the importance of natural history studies, is to determine baseline. What's going on normally in children with achondroplasia? How fast are they growing? Information that we didn't have before. BioMarin came along and said, well, we've got this drug to try, but before we trial it, let's find out what baseline is like so we can have some idea of what our intervention might do. So natural history studies are key in any rare disease trial, but have been particularly key in achondroplasia. And it's allowed us to determine what growth is like for children with achondroplasia. We have now collected thousands and thousands of data points about normal growth in children with achondroplasia, allowing us to build up these growth curves, and particularly for determining the annualized growth velocity, which has formed the primary endpoint for many of the trials that we have run. So lots and lots of data points to establish what normal is like for children with achondroplasia. It looked like the thing might work in the mouse, but before we can see if it works in children, we've got to test whether it's safe, whether it's tolerable. Are there any terrible side effects? Is this going to work? And so what we found out from the phase 2 study was not only was it safe and tolerable, but it looked like it was having an impact upon growth. So over a 7-year, so we started this study in 2014, so it's nearly the 10-year anniversary, celebrations to be had. We have collected much data over this period of time in a very small number of children, because this the overriding objective was to show that it was safe and tolerable, but whilst doing that, we were also interested to see if there was any effect. And over 7 years, we were able to show an improvement, an increase in height Z-score. So that encouraged us. It was safe. It looked like it might be doing something good to go for a phase 3 study, which is the pivotal study. Is it beneficial? Is it efficacious? So this was a randomized placebo-controlled trial with children who were in the natural history study, about 120 children or so, 50-50 randomization to drug or placebo over the course of a year. The children on placebo carried on growing at the same rate as they were in the natural history study. This is the orange line. But in the children who received vosoritide, there was an increase in height velocity of about from a baseline of 4 centimeters a year to 6 centimeters a year, so 2 centimeters more of increase in annualized growth velocity. And when children on placebo were then given the drug after a year, they too started to grow at the same growth velocity as the children who had been on active drug, and they continued to grow at that rate. So this is a response that is sustained, so very different to growth hormone if we're still inclined to draw comparisons. So the increase in annualized growth velocity was 1.5 centimeters a year, and the increase in height Z-score was 0.28. Both of them beautifully statistically significant, but just harking back to Sérgio's words that it is crucial if we're thinking about an additional 1.57 centimeters a year to get that right, to measure that accurately, because if you're out by 0.5 centimeter, that is huge in terms of an error in monitoring response to the drug. And then equally, you might think 1.57 is not very much. What's all the fuss about? Well, the effect of vosoritide is in its cumulative impact. So 1.5 centimeters to 2 centimeters a year, maybe not very much. This is additional growth. But over the course of 5 years of treatment, that's another 10 centimeters of growth. And Antonio might give us some context for that around his in his talk about limb lengthening surgery and how that compares. And the other thing that we were interested to know was what was the effect on puberty, on the pubertal growth spurt, because children, as depicted by this pink purpley line here at the bottom, girls and boys, don't have a pubertal growth spurt, and that's very common across all skeletal dysplasia types, whereas children without achondroplasia do have a growth spurt. Here's the orange line. So what happened to children with achondroplasia who were treated with vosoritide, that's the blue line? Well, they didn't appear to have a growth spurt, but what did happen was that they continued growing more for longer. So children without achondroplasia and children with achondroplasia untreated stopped growing, whereas children with achondroplasia, although their growth velocity slowed down to 0, but children with achondroplasia carried on growing at a higher annualized growth velocity for longer. So we think that there might be a final kick to growth to get those kids into their final adult height. Again, an increase in Z-score over 4 years of 2 standard deviations. So that's very impressive response to and sustained response, and it looks like there's a tendency towards an improvement in the disproportionate short stature. So the body disproportions look like they're tending to improve, which is an important consideration when we think back to the last session where we were thinking about disproportion and its impact on psychosocial things and on functionality and health-related quality of life. So tendency towards an improvement. So that was in the children 5 and older. So we now accept that achondroplasia is not just disproportionate short stature. It is a medically important, complicated, serious medical condition. And some of those really serious issues occur in infancy when there is a 50-fold increase, for example, in sudden infant death. So what might the drug do to the younger children? Could it also improve outcomes in the younger children, so 0 to 5? Again, another randomized placebo-controlled trial, and we were able to determine from the previous studies, including the natural history study, that the growth rate in children with achondroplasia, just as it is in children without achondroplasia, is very interesting and busy in the first 2 years of life, where there is this dramatic decline in annualized growth velocity. So pretty much if we think about growth velocity itself, and we're trying to improve that growth velocity, we are effectively swimming against the tide. The growth rate is declining rapidly, and we're trying to pick it back up. Very difficult. But when we view things in terms of what it's like, what it does to growth compared to children without achondroplasia, what we see is after 4 years, if you consider that children without achondroplasia grow at 100%, children with achondroplasia who are untreated grow at 65%. Children with achondroplasia who are treated with vosoritide grow at 90%. So that's nearly a 100% restoration of growth in children with achondroplasia who are treated with vosoritide. And in respect to those severe complications, well, things like we see an improvement in face volume, in sinus volume, and very excitingly, an improvement in the foramen magnum size. So that is one of our main concerns in infants with achondroplasia, foramen magnum stenosis, conferring that 50-fold increase of sudden infant death if it's not detected. Also causing severe sleep disordered breathing. If we can improve the size of the foramen magnum, it's going to alleviate some of those severe complications. And that's what we're starting to see in these very young children. Early data, small numbers, but it looks very encouraging. So I think I have some more slides. I was going to talk about the other treatment landscape in achondroplasia, to let you know that, as I've already alluded to, that this is a very busy space, that there are other trials in running in achondroplasia. For example, the trial run by QED BridgeBio using an oral preparation called infigratinib, which is a tyrosine kinase inhibitor. It affects the way the receptor itself works. And in phase 2, we identified that it was safe and tolerable. And at the highest dose, the 5th cohort dose, there looked to be an excellent response in respect of the annualized height velocity, which increased to 7.7 centimeters a year. So compared with baseline, which is around 4 centimeters a year, that's an additional 3.7 centimeters. Very exciting. And that's being closely followed by another trial run by Tyra using Tyra 300. So infigratinib is a tyrosine kinase inhibitor specific for FGFRs in general. Tyra 300 is specific for FGFR3, so being much more targeted towards achondroplasia and the FGFR3 receptor itself. And both of these will stimulate 2 pathways that are activated by the FGFR3 signaling pathway, the STAT pathway and the RAS-MAPK pathway, whereas vosoritide, C-natriuretic peptide, is focused on just one pathway, the RAS-MAPK pathway. I'm doing this without pictures. And there's also another longer-acting C-natriuretic peptide, TransCon CMP, which is a weekly injection of CMP that's not synthetic, but it is contained within a vehicle, which when it is injected subcutaneously once a week, is slowly released and will have potentially the same effect as vosoritide. And that is in trials as well. And phase 2 studies have shown that there is an increase in height velocity in children who receive the drug. That's in phase 2. It's being trialed now in the phase 3 setting, as is infigratinib. And so we await those very exciting next steps with data. I was also going to tell you about drug repurposing, because these are very expensive studies. They take a long time. There's meclizine as well, which seems to work on the same pathway as C-natriuretic, as CNP, but meclizine, good old-fashioned drug that was developed to treat as an anti-sickness drug, an antihistamine for to counteract sickness. Looks like it too could have a potential effect. And I know that there are some academic institutions who are also trialing meclizine as a potential quicker, cheaper alternative to this drug. I think that was all I was going to say in my slides that I'm imagining in my head. So with that, I will hand over again to Antonio to talk about limb lengthening and how, so that will set us up for our discussion after his talk, although he's got to leave at past, about how we can potentially combine these things in the future. Thank you.
Thanks, Melita, for the presentation. Do you hear me?
Yes, thank you, Antonio.
Okay, perfect. Thank you, Melita, for the presentation. And thanks again to European Achondroplasia Forum, the steering committee, for giving me the opportunity to take part in this amazing project. I think now, okay. Exploring, the title of the presentation is Exploring the Future of Treatment. Huge number of questions. Why to treat? Options of treatment. Advance in research, like Melita exposed us in a masterly way. New paradigm, dual therapy, future perspectives. We start with the first question, why to treat? The reason of the treat in achondroplasia patient are the comorbidities, better known than years before. Comorbidities, relationship with foramen magnum, spine, respiratory system, metabolic, extremities, and limb shortening. An option of treatment. Grove 2021 categorized into surgical and pharmacological therapies. In one hand, surgical treatment for treat in isolated way each comorbidity. Foramen magnum with decompression, spine with fusion, tonsillectomy, adenoidectomy, tympanostomy, correct lower limb malalignment, limb lengthening, or medical treatment with the future idea to treat all the comorbidities with one shot. Thank you to the knowledge grown up in 1994 and 1996. Today we know the physiopathological mechanisms and different molecules are in investigational phase. Molecules developed by BioMarine, Voxzogo, only approved molecule with evidence in annual velocity growth, proportionality, and health-related quality of life. By Ascendis Transcom in phase 2, escalated doses phase. By QED infigratinib phase 2 and phase 3, an oral molecule with promising results in annual velocity growth. By Sanofi monoclonal antibody phase 2, escalated dosage phase. And Tira in preclinical studies. Due to the huge number of possible surgeries and the different medical treatment in clinical trials, and the medical treatment approved, vosoritide in this case, arise a possible concept, a concept or possible option like Campbell and Professor Ravi expose like an expert opinion. We can't forget that expert opinion is a level 5 evidence. And this is the opinion, how these therapies compare, and if they might be used in combination of this medical treatment. Idea already presented in the first paper referring the clinical trial phase 3 in Lancet in 2020, leadership by Professor Ravi. Any of their actions may be synergistic for possible future combination therapy. Always talk about medical treatment. However, up to now, in relation with medical therapies, we have answered only around annual velocity growth, proportionality, and this year about health-related quality of life. Therefore, we assume that vosoritide have an impact in this comorbidity, limb shortening, short stature, and body disproportion. But we don't know if they have long-term information around the rest of the comorbidities. We don't have answer around the rest of the comorbidities. In this scenario, these different questions arise. First, if medical treatment influence in the rest of the comorbidities, and this medical treatment influence in the surgeries of these comorbidities. More question. It's possible a medical treatment combination, like was referred by Professor Ravi, but in that affirmation, it was not mentioned the possibility to combine medical and surgical intervention option. And we have to open this way. This is the third question then. Medical and surgical combination to treat different comorbidities. Focusing in this third question, why not add the effect of the medical and surgical treatment like limb lengthening to treat the most characteristic comorbidity, limb shortening, short stature, body disproportion. If we deep in this option, relationship, limb lengthening, we have to know that in the last consensus, it was referred that there is no consensus if surgery should be performed, which methods to use, and the timing to start. In my opinion, limb lengthening is an option in those patients who have skeletal dysplasia, is more severe with more limb shortening, short stature, and body disproportion, and therefore more implication in health-related quality of life. Lengthening could be an option, of course, not for all patients, only patients who health-related quality of life is lower, and of course, not extensive limb lengthening. Probably you have heard me to redefine the term limb lengthening to health-related quality of life limb lengthening. If this idea is a possibility, emerge more questions. medical treatment influence in health-related quality of life limb lengthening? Is possible a dual therapy? Candidate, approach, when start, when finish, objective, tools to measure this objective. We will try to give answer to each question, but the only way to get answer is research and more research, I think. Medical treatment influencing health-related quality of life limb lengthening, it's a very good question. Have vosoritide effect in the osteotomy? What is an osteotomy? It's an artificial fracture that we perform to get elongation callus. Then have this medical treatment vosoritide effect in this osteotomy, or have effect in infection rate, or in the elongation callus? That is very, very interesting question, because we know that in the callus there is an intramembranous ossification process with collagen type 2, and in the feces is an endochondral ossification with collagen type 10. Is too much stress to the feces the added effect of medical therapies and elongation? It's necessary research this. If we interpret that dual therapy is an option, we have to know perfectly both treatment. Nowadays, the evidence situation in both therapies, in health-related quality of life, limb lengthening, we talk about level of evidence, 3rd, 4th, and 5. Safety with hundreds of complications is a very aggressive surgery. Efficacy in skeletal comorbidity, but unknown in terms on health-related quality of life. And of course, there is no acts in the rest of comorbidities. And in the other hand, we have pharmacological therapies have already been exposed with a level of evidence 1. Who is the candidate? Who could be candidate for this option? What is the indication for this option for dual therapy? First, I think patients who could benefit from synergistic effect between health-related quality of life and lengthening and medical therapies, because skeletal comorbidity is very, very severe. This is the first candidate for this dual therapy. Second, patients who limb lengthening has been performed, and these patients have open phases and could benefit from medical treatment. This is the second candidate, probably. And third, patient in medical treatment and bone surgery is needed, for example, not only limb lengthening, and osteotomy too. And the last one, patient that they are in medical treatment, and we see analyzing the different variables that they are not responders or good responder to medical treatment, and limb lengthening is an option. I think this is probably are a very good candidate for this option, the dual therapy. And what is the approach? Assuming that all patients will be treated with pharmacological therapies, understanding that health-related quality of life and lengthening like an option to treat some comorbidities in some patients, and non-long-term medical therapies efficacy, dual therapy, I think it's a real option in our area in this time. But what is the best approach? Different possibilities could be performed. Parallel and consecutive therapeutic approach. Vosoritide, after that, vosoritide plus health-related quality of life limb lengthening in the same time. And after limb lengthening finish, vosoritide again. Another possible approach, consecutive therapeutic approach. Vosoritide. When limb lengthening is performed, we stop the medical therapy. And after limb lengthening is finished, we restart the medical therapy, in this case, vosoritide. The only way to know safety and efficacy with this approach is, again, research. We are performing now a study titled Safety and Efficacy of Dual Therapy, Vosoritide and Lengthening in Pediatric and Adolescent Achondroplasia Population, approved by the Malaga Provincial Ethics Committee. And another good question, when start? We know that medical treatment as soon as possible. Up to now, in Spain, less than 2 years old. We are waiting that probably is approved in less than 4 months. And health-related quality of life lengthening, in our case in Spain, it's around 11 years old. It's very variable around the world, around the countries, in Italy, in Australia, in Germany, different age of start. Normal situation around 10, 11, 12 years old. In this case, the patient have the physis open yet. Probably this is the moment of this option, this dual therapy. We can know if the medical treatment is good or not for the patient, if the patient is good responder or not, and if limb lengthening is an option in that moment. And the main question, what is the objective? As difficult to know. Do we focus only in height? In which comorbidity do we center our objective? As taller as possible? I think this is a ground approach. What is the minimum anthropometric measurement required to get clinically significant relevance? We don't have answer about that question. The first group that talked about an anthropometric measurement, like an absolute number of height, relationship with better physical domain in health-related quality of life, was Matsushita et al. 2019. They talk about a treatment strategy would be planned to gain a final height of 140 centimeters or taller during childhood in combination with growth hormone administration and limb lengthening surgery. It was visionary because he talked about the combination of medical treatment and limb lengthening. But it's wrong in the medical treatment. He talked about hormone administration. Probably we have to change these both words and put medical treatment, or in this case, vosoritide and limb lengthening surgeries. Then talk about these combination therapies. Probably this is the way. It's a really good approximation, but more complex analysis needed. Not only talk about height, of course, it's important, but we have to agglutinate the rest of variability, of variables. Challenge, big challenge. We have growth chart from Swedish, America, South America, Australia. We need charts around medical therapies. We have to create new charts in patients with medical therapy. We need predictor tools for patients which medical treatment is performed or combined treatment is performed. But our big objective is maintain ourselves in alert. Our principal mission is perform pharmacovigilance. And for this pharmacovigilance, we need power tool that Sérgio told us before for capturing the most important event. When was limb lengthening started? When was medical treatment started? When has poverty started? And how are anthropometric measurements modified after this event? In summary, we are ready to create evidence about dual therapy in terms of efficacy and safety. First, for patients in which health-related quality of life limb lengthening has been performed. And second, patients who could be treated with both therapies from the beginning. We have to look for a personalized, safe treatment, one patient, one treatment. Thank you very much. Melita, sorry that I have to leave you because I have to go to the surgery room. Is there any question? I am at your available. I can put my email in the chat, and whatever you need, I am totally you. Okay?
Yes, thank you so much. Good luck with your next task. And thank you so much for your time today and sharing your expertise. Thank you, Antonio. See you soon.
Thank you very much. Bye, Melita. Thank you very much.
Thanks. He leaves us with food for thought. Yeah, so I recognize that on a couple of occasions this afternoon, we've brought in experts to provide us with answers, and the experts have said, I've no idea. So I guess that may bring us to around to thinking, well, if the experts don't have any idea, what hope do the rest of us have? I think what we're trying to achieve by doing this workshop this afternoon is to try and answer some of those questions. And as you will see when we sign off, we're not signing off yet, I don't think. But as we sign off, what our plans are, where we intend to take this. So we would be very grateful for as much discussion from you all as well. You've heard us speak a lot, but we'd be grateful to know your thoughts too, so that we can start to develop some of these things and find some answers and be a bit more definitive about how we should look after children with achondroplasia in view of all of these new drugs. So Antonio has left his email in the chat. Thank you so much. Does anyone have any questions? Any points to make? Has that stimulated any thoughts? I think it says to me that we must, more so than ever, really make sure that we get these tools right and get our outcomes assessed accurately, because it's going to be important to demonstrate efficacy or not in many of these potential therapeutic interventions. How will we begin to know whether Antonio, his notion is correct, that combining vosoritide for improved health-related quality of life, vosoritide with health-related quality of life limb lengthening procedures is effective? What is, maybe vosoritide is effective enough? Maybe vosoritide in combination with infigratinib might be effective, drugs at different times. How will we begin to separate out those different things if we don't collect the data accurately right from the word go? So people on the shop floor, do you think this is possible? Have you got any tips for us as we develop these plans about how this data can be collected in a realistic way?
Can I make a comment?
Yes, please,
Melita?
Mohammed.
Yeah, I mean, I agree, because the issue of non-responders or poor responders will be a big challenge. At which age, how to deal with other treatments, and which patient to discuss with in a shared decision-making about limb lengthening. So I think also these parameters and how to define at which age are extremely important for everyone.
Yeah, absolutely. Yes. And again, we have different practices in different countries as well. I liked Antonio pointing out, I don't know if he meant to be ironic, but he said the consensus is there's no consensus about when limb lengthening should be started. But it is true. I think I've heard Sérgio say several times today, this raises more questions than provides answers. It does. We are still very much learning about this area, and the more and more we find out, the more and more we realize there is to know. Yes, thank you, Siobhan. Siobhan has put in a comment to the chat. I'm sure this is being done, but I want to emphasize the need to understand and record quality of life data for those not receiving treatments. Thank you, Siobhan. Yes, good point. At skeletal dysplasia appointments. Yeah, absolutely. Yeah, I think that again emphasizes the need to establish these registries, to establish a very coherent way of collecting information, so that we can not only map what normal is like, but we can identify areas of need, whether that is addressed by medical therapies or in other ways. I think, yes, Siobhan makes a very good point. Thank you, Siobhan, and nice to have you on the call. Yes, anyone else have any thoughts about what we've discussed this afternoon? Any aspirations for combination therapy?
Maybe, Melita, yes, this discussion on combination is very important. We need some patients still, but when we compare with other disorders such as cystic fibrosis or others, than that, when you remember that it took about 15 years to go from a single therapy to this combination that totally changed the life of these patients. And of course, our first aim as a physician is not to harm. So we all agree that it's better to have moderate dosing of each product and to try combination than to go with a higher dosing and to have risk, especially with such drugs, FGFRs inhibitors and other that are probably important in childhood, and especially if we want to go quite long in the life. So combination is probably the way, but not too early, and we have at first to be sure of the PK, pharmacokinetics, and toxicity, and then to try combination, and possibly quite early. And we are probably these are already started in preclinical works. That is our aim.
Thank you very much, Geneviève. Thank you for sharing that. We have a couple of comments in the chat as well. Thank you. Rasha asks whether there are any recommended videos or resources, or are there, to know the exact way to take accurate growth measurements for achondroplasia patients. Rasha, there are lots of resources on the EAF website, which we will give you. Maybe somebody from the team could once again put that in the chat, please. There are lots of resources on there. There are podcasts and various talks that we've done, and publications. Sérgio has already alluded to a publication that we're currently developing, which is around how to take accurate growth measurements in achondroplasia patients, because it's not straightforward. It is technically difficult, as colleagues of mine on the call will know very well. And so, yeah, it takes a certain technique to be able to do this. And so a group of individuals who've been very experienced in this over the last 10 years or so have contributed to this manuscript. And I think Sérgio is right. It's going to be published in the next month or two. So look out for that. And can we use the usual standing scale for sitting height? Again, that's going to be in the publication. There is a podcast on the EAF website which also addresses this. But the answer is yes, but with a block to sit on. And then you subtract the height of the block from the sitting height. So positioning is very, very important in these children, because we're dealing with such small changes. So yes, you can, but there's a certain way to do it. Monica, thank you very much. Yes, what Monica's asking in the chat, what about vosoritide and growth of spinal canal? Has it been sized? Because I've read about foramen magnum, but nothing for spinal canal. Maybe it would be good, better size in adulthood. Yeah, that's what we're hoping for. We think that many of the benefits of medical therapies for achondroplasia in childhood will last into adulthood. And as Svein has already said, maybe he'd like to chime in again here once more. As he has already said, there is I think you said 78% incidence of spinal stenosis in adults with achondroplasia. It is a major cause of morbidity in those people, and really affects them significantly. So aspirations to change the dimensions of the spinal canal is also part of the studies. Svein?
Yeah, I think I've been working quite a lot with the adults, and I think spinal stenosis is definitely on the top of the list of kind of the medical trouble you can get into when you grow older. So more or less, it seems to be a matter of time for most people with achondroplasia, whether they will have a spinal stenosis or not. So if we could have a link, I mean, if you can demonstrate, as you showed us in the infant group, that there could be an effect of vosoritide and the other drug treatment on foramen magnum, but for the adult population, it will be kind of even more important maybe to demonstrate that it is also an effect on the spinal canal. So of course it will take time to get those data in a real world adult population, but I still think if we can at least see an increase in the spinal canal diameter, which is probably would be possible to see at an earlier time than when the spinal stenosis occur, because that can vary between like 10 years of age up to 60, 65. But the mean, at least in our study, was around 33, 34 years of age. Then half of the population had developed spinal stenosis, and up to 80% would have had developed spinal stenosis when they turned 45. So that's definitely, I think, on top of the list, and also have a really huge impact on the ability to walk, on pain, and also the ability to participate continue participate in the work life and social life. Because if you have a severe spinal stenosis and you get bladder incontinence, your social life is also impacted. So this is also a huge effect on the health-related quality of life.
Yeah, and it causes significant morbidity, Svein, doesn't it? In respect of it, at its worst, it can cause paraplegia. So
yeah,
it is.
And what we see is usually after the first surgery that might be successful, but when you come to the second and third and fourth and fifth, the degree of success is rapidly declining. So, and many of these patients end up in a wheelchair or really big walking issues. So I think this is a part of it, not all, of course, but I think that's a big issue to address. And of course, if we could link the current treatment to the spinal canal diameter, that will be a really significant contribution to justify why we should start treatment
Early. Yes, and that reminds us that achondroplasia has a significant impact into adulthood as well. So just as children at certain ages have different complications, adults have a similar set of complications that are age-based, and this doesn't stop at 18. And we had the previous workshop that we had was focused very much on how we advise care for adults with achondroplasia to be carried out, realizing that this is a very different space. They are no longer children with parents who are advocating for them and doing things for them. They are adults with adult lives to live, and how factoring in an awareness of their condition, but allowing them to get on with life just like adults without achondroplasia would, is treading a fine line. And so education and empowering people to be in charge and responsible for their own healthcare, we think is also going to be beneficial in the long run. There are resources on the EAF website that you can look back on to see that workshop as well, and a publication to come from that. Silvio, thank you for your question. What is the minimum stature to improve the quality of life? Because this can be different between different populations, and vosoritide can be able to reach this stature in very young patients, but now we have to take care of older children. And for this reason, I think that combination therapy is important, but we do not have sufficient data on the influence of vosoritide or on limb lengthening. Absolutely. Yeah, so that's a multifaceted question that you pose. Yeah, but agreed, we don't have sufficient data yet. Again, this is one of those situations where the more questions you ask, the more you try and answer, the more questions you're left with. But yes, that's again underlining the importance of collecting accurate data in the setting of the clinic in the real world, and making sure that we are capturing everything, whilst acknowledging that these clinics are very busy. So we can't not do it because we're too busy, and because it's going to impact the future care significantly. And what will happen in combination? Well, what might we expect to happen? We don't know. To my mind, just to throw out some ideas there, it could be that vosoritide is very effective at improving the dimensions of the foramen magnum, but then infigratinib is much better at that pubertal growth spurt, or perhaps in combination in the middle of childhood reduces the comorbidities that occur. Who knows? But and what the role of the drugs, either individually or indeed in combination on limb lengthening, will be, again, is still a very much unknown territory. So collecting information around this is very important. And I think, again, your question also underlines the fact that we have different expectations in different countries. Every time we meet as the European Achondroplasia Forum, we acknowledge that expectations are different in different countries, and we embrace those differences. Before he left, Antonio told us about the expectation in Japan, where minimum stature is 140 centimeters. Whereas in the UK, that is not necessarily what we're aiming for. We're just aiming for improved quality of life, because stature may still be short, but disproportion has improved. So there are different things that we will all look at. And the fact that there's no consensus, there's no consensus on when to start limb lengthening surgery is really, again, reflected in the ages that happens in different countries, where this is a common procedure in children with achondroplasia, whereas in other countries it's not a common procedure at all. So there's still much variation, which will always be, and as long as we acknowledge that and embrace that, then we will all we'll all get on just fine. Okay, anybody else want to add to that? Sergio's back in the house. Hi, Sergio.
Hi. Can I add, maybe we could make some kind of recommendations to try to, that all the pharmaceutical companies could have also how the way they present the data and collect and present the data to be more homogeneous. Because even, I don't know if EAF would be the right forum for that, but with EMA or with other regulations, I think there's so many years ahead yet that I think it could still be useful to propose, because now that we have experience in several clinical trials and they kind of present the data in different ways, the average for the responders, others put the average for all the group, and the other, and also for that some will have measurements on other things, others not, and quality of life. So could not we, at least for the data that is more to kind of help the regulatory authorities to have a guidance on what they can evaluate and compare better? Because I think it will be very difficult to compare, even as you mentioned, Melita, how did we compare the efficacy in this and that if they measure it in different ways?
Yeah, I agree 100%. And we have several of the companies represented here today. What we're really underlining is how important it is to not only to collect the data, collect it in a consistent and accurate way. These drugs are here for, for the long game, and 1.57 centimeters a year or 3.3 centimeters additional growth a year is not much to write home about. It's the cumulative effect that is going to be the value of these treatments. And all of these beyond height outcomes as well will take a long time to collect. So I think it's in everybody's interest. It's in the interest of us as healthcare professionals looking after these children, and people looking after adults with this condition as well. It's in the interest of parents to know how their child is responding. It's in the interest of the commercial companies with these drugs to to market, that we are continually showing an effect, ideally a benefit, and really having the data at hand to be able to show what these things might do in combination or not, and who these drugs might be targeted better for. So those slower responders might be a better responder for one drug than another, for example. So if there's some way that we can galvanize the companies to help us with this long-term data collection, I think that might be a really good way forward. So yeah, perhaps that's something that we can consider, understanding commercial sensitivities, but also recognizing that we are all singing from the same song sheet, and this will benefit us all in respect of our outlook for looking after people with achondroplasia. Ciao, Silvio. Thank you for joining us. Do we have any other points before we? It's fine. Please,
Yes,
please.
I'm just trying. Yes, thank you, Melita. I'm just trying to think what could be or what should be the next step after this workshop, because I think Sérgio has already addressed this. That I think you have quite showed us quite clearly that it's necessary and important to do measures, and we should do it not only on height, but we need to expand also to medical complications, to a health-related quality of life, to function. We have seen all those different instruments that could be used. So the question is, would it be possible, or could we discuss at some point whether this forum, because we are quite many nations and countries involved, to develop a kind of core set, come up with some consensus on a core set of instruments or measurements that we think should be used. I mean, there are different registries now, like CRESCNet and the Euro-RR, who use different kind of measurements, but I don't think there is anything that's kind of consensus based. And again, based on previous experiences with international consensus guidelines, maybe that could be a topic for a in-person meeting, because when we have nothing to start with, it's always, I think, easier to have people in the room, having separate groups, split up and come back and discuss, and maybe come up with some kind of core set or consensus. So just want to bring it on the table, and because I think we have recognized the need for this, but how could we proceed and get something down to on a paper that actually could be published and could be a start at least for some consensus.
And yeah, I like your idea of an in-person meeting, and that would allow us to make it as multidisciplinary as this kind of discussion, if we take it forward, would need to be, because we need our allied health professional colleagues as well to contribute to that with their vast experience too. So yes, I think that is a very valid point. Thank you for sharing that thought with us, Svein. We are heading towards the close now, unless anyone has one final burning question. Because if not, I was just going to tell you about our next steps. So having had this meeting today, which requires me to have access to the slides, please, Zeus. So in respect to the next steps, well, the slide survey results that I spoke to you about, the very first thing we did today, will be available on the EAF website in their entirety. So I didn't present all of the data. I just really focused on the data regarding the outcome measures for treatment with vosoritide, but we looked at other outcome measures as well in respect of in the absence of vosoritide as a therapeutic treatment. What we'd like to do as well is to put all of this together and submit as an abstract to the European Society of Pediatric Endocrinology, to ESPE, for the meeting later this year, again with a view to putting this on the agenda and taking it to the next steps, such that we should be able to produce a manuscript to direct us where we need to go in terms of all the considerations that we have, all of those unanswered questions, all of those times our experts today have said, I don't know, trying to find out what the answers are to that, trying to know, so that we can really improve the way we collect data consistently across everybody's centres to do this, to do the best thing for our patients. So with that, I would like to thank everybody for coming. Thank you so much for your time. Thank you so much for your participation today. Thank you for all you're doing for patients with achondroplasia and for really paving the way. I always say that when you talk to me, you might be forgiven for thinking there's just one rare disease, but in fact, there are 9,999 others. And what we're doing in achondroplasia is really paving the way for what others can do for all the other rare diseases and rare conditions as well. Whereas my colleagues in Hong Kong, I think some of you are going to be listening later, as they say, the uncommon conditions. With that, please complete the evaluation questions that will appear when the Zoom meeting ends. Won't take long, but we really would be grateful for your feedback. Just tell us quickly what you think, and that will help us for future workshops. And please check out the EAF website for more resources, and also achondroplasia.expert. It's another area where you will find lots of resources as well. So thank you all for coming. Have a good evening and see you next time.